Good afternoon. Again, as Casey said, my name is Pamela Gekas. I do treat patients in Bryn Mawr, South Philly, Glen Mills, and Media. And even though I'm busy, I'm more than willing to see anybody that needs any help. So today I'm just going to talk a little bit about common foot problems and the treatment options. I might not get to all of the ones. You guys might have some other problems that you might put them in the question, and if we can get to them, I'll certainly answer them for you. So the ones I picked were the ones I see most of the time in my office. So I see a lot of plantar fasciitis, bunions or hallux valgus is the medical term, hammer toes, hallux limitus, neuroma, osteoarthritis or arthritis, and then a lot of ankle sprains. So first talk about the plantar fasciitis. It's one of the most common causes of heel pain. And what happens is that the plantar fascia attaches to the heel bone. It's called the calcaneus, and it gets inflamed right at the insertion. It inserts into the medial tubercle of that calcaneus. Most of the time, we can get you healed without needing surgery. So about only 5 to 10% of the people require surgery. Most of the time, conservative treatment options can heal. But you have to be patient. It's not going to happen overnight. I'm not going to see you one day and the next day you're going to have resolution of that pain. The symptoms are normally when you first get up in the morning or after getting up from a sitting position, you have pain in the bottom of the heel. If you stand for long periods of time, you're also going to see pain at the end of the day. The pain does subside as you move. So you get up in the morning, you have that severe pain, you take 4 or 5 steps, and that pain will start to get a little bit less. The more you walk, it goes away. The minute you sit down and get back up, the pain returns. It can happen as you're driving and you get out of the car. You can see that pain also. The picture on the left will show you right where that plantar fascia inserts. You see that little red spot there? That's where it gets inflamed when it inserts into that heel bone. So normally we don't necessarily have to see a heel spur. Patients will come in, do I have a spur, doctor? And I'll say, I'll take the x-ray and we'll see that there's no spur, but it's the inflammation of the plantar fascia inserting into that heel. Is it related to footwear? Most of the time, I do evaluate patients' footwear and I'll see that they're wearing the wrong shoes, non-supportive shoes, too flat shoes. So the risk factors with plantar fascia, with this COVID-19 pandemic, we've seen a lot of people come in and say, you know what, doc, I haven't been able to exercise, I haven't gone out to the gym, and I've gained a lot of weight, and now my feet hurt, my arch hurts. So we do know that if you're carrying any extra weight, we're going to see that that is a risk factor for plantar fasciitis. Equinus deformity. So an equinus deformity is when you have a very tight Achilles tendon. So you have a tight Achilles tendon that normally leads you to tightness in the plantar fascia. Another risk factor is poor shoe gear. So a lot of times I'll have patients come in and say, you know what, I've been working from home with this pandemic. I've not worn any shoes. I've worn flip-flops, or I've just worn socks or slippers. So after a year of just working in the house and you're standing up, we even have patients that have said to us, I've worked out without any shoes on in that house, and they've gotten pain. So we know that we need to give you some support with your feet. So the better the shoe wear, the less chance you'll have that plantar fascia pain, or the quicker that plantar fascia pain will resolve. Biomechanical abnormalities. So we know that plantar fascia does occur in people who have very flat feet and people who have high arched feet. So if you have a very flat foot and you're wearing very non-supportive shoes, you're going to have a chance of getting plantar fasciitis. And then one of the last risk factors is the work surface. So if you're working on a lot of hard concrete floors or hard floors, we're going to see patients who are wearing non-supportive shoes, again, on these hard surfaces. That's a risk factor, and we're going to see more of that. So the treatment, when a patient comes in, I'll evaluate them. I'll evaluate their Achilles tendon to see if that's tight. I'll evaluate their plantar fascia to see if that's tight. I like to see them standing up. I want to see, do they flatten out when they stand up, or do they have a high arched foot? I'm going to ask them to stop doing any high impact activity. So if you're a runner or you go to the gym and you're using the treadmill, I'm going to ask you to stop using that and stop running. I'll give you opportunities to still get some cardio by swimming or using a bike or spinning or sitting in a sitting position and lifting, but I don't want you to do any high impact activities like Insanity or the treadmill running or Orange Theory. I'm then going to ask you to start doing some stretches on the Achilles tendon and the plantar fascia, including eccentric stretches. So I'll actually ask you to do them 2 to 3 times a day for the first month, because I need to make sure that we're getting them stretched out. Once we get resolution of the pain, and if you still have tight Achilles tendon and plantar fascia, I'm going to ask you to at least stretch them once a day. If you have a lot of pain, I'm going to ask you to take some anti-inflammatories. I'm going to ask you to stop going barefooted. I want you to wear supportive shoes. So with this pandemic, a lot of patients are coming in and saying they're not wearing shoes at all in the house. I'm going to ask you to start wearing shoes in the house. Even though you're not going out of the house, I'd like you to wear something on it to give you more protection. If you have a biomechanical abnormality, I'm going to ask you to consider orthotics. We have over-the-counter orthotics here. We also make custom molded orthotics. And the custom molded orthotics are made specifically for your foot. So what we'll do is we'll cast your foot, we'll make the correction to the cast and make you an orthotic, which is an insert that goes into your shoes. If you have a tight Achilles tendon, I'm going to put you in a night splint. That keeps you in a 90-degree angle. That takes that stress off of that Achilles tendon. If the stretching does not help that you're doing on your own, I'll recommend some physical therapy, and I will include the Graston Therapy. And what that is a deep massage with an instrument. It helps, but it's painful. So I'll have patients say, you know, I've been stretching, but I just don't feel like I've gotten that tightness out. I will make that recommendation to go to a physical therapist and let them help you to get more of that tightness out. One of my last resorts is putting a patient either in a cast or a boot to see if I can just calm them down and immobilize you. If that doesn't help, we could try a cortisone shot. If the cortisone shot doesn't help, then I'm going to recommend surgery. But again, with plantar fasciitis, only about 5 to 10% of the patients who have plantar fascia will require surgery. 90% of the patients, if they give themselves enough time to do the stretching and change their shoe wear, I think they will get resolution of that pain. The next common deformity that I see is a bunion. Hallux valgus is the medical term. And what is a bunion? Well, a bunion is a bump on that, it's a bony prominence on that medial aspect on the inside of that big toe joint. It is a progressive deformity, so you will see that over time it will get larger. The pressure from the shoe wear that will cause that big toe to move towards the second toe, and then over time you'll see that bony prominence on the big toe on the inside, and that's the bunion. Bunions become painful when patients wear too tight of shoes, or patients who wear heels and squish their feet into the heels, or wear tight shoes that put the pressure there. What we'll see is we'll see a very red and swollen first toe joint. At times it becomes so painful that even wearing normal sneakers that are wide enough cause pain. It will eventually restrict movement of that large toe joint when it gets so large. What are the causes of the bunion? Well, usually it's hereditary, but we'll also see it in patients who have rheumatoid arthritis or any type of arthritic condition. It also can be caused by an injury to the great toe joint. As I said earlier, it is aggravated by heels or ill-fitting shoes. One of the things I'll ask patients to do, when is the last time you got yourself measured? Right? The last time I got myself measured was probably when I was in high school. So over time, we do know that our feet flatten. They don't get larger, but they flatten. So I recommend that you go to a good shoe store and get measured in the Brannick device. It's that metal device. You stand up in it and they'll measure the width and the length. And what I find is most patients are probably in the wrong width shoe, and sometimes they're in the wrong length. But that's one of the biggest problems I have is patients are really in the wrong size shoe, mainly in the width, But if you can buy a wider shoe, you'll find that your bunion pain will go away. In severe cases of bunion, you'll see that the big toe will push over to the second toe. It's either going to override that second toe or it'll go underneath the second toe and cause a hammer toe. So here on the left-hand side, you can see this bump on that great toe joint, and that's what the bunion is. And what you'll see is that great toe shifts over to that second toe and pushes over into there. Occasionally, you'll see that that second toe is either going to ride above that large toe or it'll go below it. And on the right-hand side is where you see the x-ray of it. And what you see is right here is where that bunion is. So you get that excess bone there. Over time, it will get larger and it will progressively get worse. What are the treatments? Again, we talked about the footwear, right? Have yourself measured in a standing position at the end of the day. And I like telling patients to do it at the end of the day because we swell up. At the end of the day, you can get a true measurement. So you might be a little swollen, you might be a little wider. So you start off in the morning and you have a narrow shoe on. At the end of the day, your foot starts hurting more. It's because you're probably having some swelling occurring. You want to avoid the shoes that are too narrow and too short. And you want to avoid heels. We know that heels will put more pressure on that bunion. So if you have a function to go to, that's fine. You know you're going to have pain while wearing those heels, but I would not recommend that you wear heels every day. There are special bunion shields that you can get. Amazon has all kinds of bunion shields, hammer toe shields, but if you're wearing a shoe and you're still having pain, but you're just quite not ready to get to surgery, there's a bunion pad that you can put over that bunion that will protect you between you and the shoe. We also discuss orthotics. Again, we talked about orthotics with the plantar fascia. They're, again, custom-made inserts that we cast you. We make the correction that's needed for the bunion. If you're having an acute stage of pain, we'll put you on a short course of anti-inflammatories. If there's a lot of pain and a lot of swelling, we'll consider giving you a cortisone injection. And then the last resort is surgery. Hammer toe. We talked a little bit about the hammer toe, that sometimes you can have a hammer toe because the bunion shifts over and hits that second toe and causes it to contract. The hammer toe is a contraction deformity of toes 2 through 5. So it really starts out, it's flexible. And so you'll have a little bend at the toe joint and you push your finger down and it can go back to its normal position. So those are easy because normally you could put a pad on that and wear your shoes and you'll be comfortable. But eventually they do become rigid. So then again, you have that contraction deformity at that toe, push down with your finger. If it does not bend and go back to its normal position, it's non-reducible. And those are the type of hammer toes that I find patients have a lot of problems with. You're going to see that they'll have pain and irritation on the top of that toe from the shoes. You might develop a corn. Sometimes you'll develop an ulcer if you have diabetes. You can see some inflammation. It becomes very red and swollen. Patients will say it burns, and the burning goes even back into the foot because of that pressure. Hammer toes are either caused by an injury. So if you had a fractured toe years ago and it didn't heal in the right position, it could turn into a hammer toe. It's also caused with tight shoes or heels. So women who wear a lot of heels most of their life, all of a sudden we'll see later on, they'll have these hammer toes that are contracted digits 2 through 5. Also, we talked about the pressure from a bunion. The bunion can shift that second toe into a hammer toe. We also will see it in any imbalance in muscles. So there are certain neurological deformities that we will see that certain muscles turn, or tighter than rest, and we'll see that that toe becomes bent. We'll see hammer toes in patients who have like a very high arched cavus foot. Treatment options for the hammer toe is padding of the toe. Again, you could go to any local pharmacist or you could go onto Amazon and you'll see that there's pads for the hammer toe that you can wear. Also wider and deeper toe box shoes. You can splint, there are splints, and then last resort is surgery. So here on the left, you can see what the hammer toe is. It's that flexion contraction right there at that joint. Again, sometimes it's flexible, sometimes it's rigid. Down at the bottom, you see two foam. So that's just like a little foam that we could put over the hammer toe to protect you from the shoe pressure. On the right-hand side is I'm showing the bottom of a toe crest pad. And what happens is as you stand on that, it will straighten out that toe. So that's only gonna work in the flexible hammer toe. Once you have a rigid hammer toe, I'm gonna recommend a wider toe box. Or if that doesn't help, I'm gonna say you really should consider surgical intervention. Hallux Limitus. So Hallux Limitus is a deformity of the great toe joint, but it's stiffness, and you develop arthritis in that toe joint. It is just like a bunion deformity where it's progressive. In time, it will get worse, and eventually you may lose all motion in that great toe joint. When you lose all motion in it, it's called Hallux Limitus. But initially it starts out where patients will come in and they'll say, I have a little bit limited motion in that great toe joint, and when I go to bend down or when I do certain positions, I get pain in that great toe joint. That large toe joint requires motion to allow us to walk and perform our normal functions. So I tell patients there are all these joints in our body that need to be able to get their motion to be able to walk and to walk comfortably. So when we start walking, we have to have flexion at our hip joint. We need flexion at our knee joint, flexion at our ankle joint, and then flexion at our toe joint to be able to propulse off to walk. So if any of those joints don't have the motion that is required, you're going to start having pain. The early symptoms with the Hallux Limitus, again, is that patients come in and say, I have some limited motion or stiffness in that large toe joint when I push it upwards. So you push it upwards with your finger, but when you're standing, just try to go up on your toes, you have limited motion or you have pain in there. And that's the beginning of Hallux Limitus. Eventually we'll see a lot of swelling, a lot of redness in it. Eventually patients will say, even when I'm not wearing my shoes and I'm barefoot, it causes me pain. And eventually you'll see a large bump on the top of that big toe. What's it caused by? Well, we know that it's caused hereditary. We see it in family members. It could be caused from an injury to that large toe joint. So if you ever broke that large toe joint and it hasn't healed in the proper position, or you develop arthritis in there. It also could be from a structural deformity to the bone. So again, that's almost hereditary. You could have that first metatarsal bone is elevated a little higher. We also see it in high arched feet. Anyone that has a cavus foot, we normally see a Hallux Limitus in it. Eventually it leads to arthritis, and that's when it becomes very painful. You see the chronic wear and tear of that large toe joint, the cartilage wears down and a bone spur occurs. The treatment, again, is getting the proper shoes, right? You want a wider toe box. You want a deeper toe box. I also recommend rocker bottom shoes. So rocker bottom shoes or sneakers, they have on the sole, it kind of curves up a little bit more so that the motion that you need in that big toe joint gets helped by your shoe. We also will use orthotics, specifically for the Hallux Limitus. We'll try some anti-inflammatories. If it's really bad and you're not ready for surgery, we'll try to give you some cortisone injections just to calm it down. And eventually, if it becomes so limited motion in there and it's so painful that even barefooted is painful, then we're going to recommend surgery. So if you look on the left-hand side, there's that dorsal, that lump on the bony prominence is on the top of the great toe joint instead of the side. And if you look at the bottom here, you're going to see that little spurring there. So that's when we first see it. We see a little bit of spurring on that bone, and this bone needs to kind of move up on that. That bone gets limited by that spur there, and now you're getting less motion, you're getting deformity within the cartilage, and you develop arthritis, where you can see that arthritis. There's no longer a joint there. The arthritis has just taken over that whole joint. You don't have any motion, and that's the one that gets really painful. Neuroma. So a neuroma is something that I'll see with patients that come in and they'll say, you know, my two toes are numb. They might say my third and fourth toes are very numb. At times I feel like there's something in my shoe or a rolled up sock. So what I do is I take my shoe off, my sock's not rolled up. I don't find anything in that shoe, but I feel that numbness. They take that shoe off, they walk around, and that numbness goes away. The most common two toes we'll see it on is the third and fourth, but we will see it on like the second and third. If you look at that picture, you see that yellow there is a neuroma. That is the inflammation on that nerve. It gets inflamed. It then puts pressure on the nerve that innervates the third and fourth toes, and you get that numbness. As the neuroma gets larger, we're going to find that patients get no resolution of pain when they take their shoes off. Treatment for that. Well, we'll first go what causes it. So you could have trauma to the nerve. You could wear improper shoes. If you kind of look at everything that we're talking about, I'm always going back to those shoes, right? So if you're wearing a lot of heels or very narrow shoes, or a lot of women like to wear those ballerina type of shoes, they're too narrow and not supportive enough. So they're squeezing those toes together. The two bones, the two metatarsal heads will squeeze and it'll hit that nerve and it becomes very inflamed. Also, if you have repetitive stress to that bottom, it's going to put stress on that nerve and you can get inflammation on that nerve. Treatment for this includes padding. So if you look at that, we'll put either a neuroma pad right on top of your foot. I like putting in your shoe because this way it's always in your shoe and you don't have to keep taking it on and off. I'm going to ask you to get out of those heels. If you're wearing a lot of heels and you know that once you get yourself out of those heels, that pain is no longer there, you wear sneakers and it's no longer there, I'm going to say you might want to consider stop wearing heels and start wearing a shoe that's wider in the forefoot. If it's just an acute phase and you want to just see if anti-inflammatories work, sometimes they do. And so I'll give you a short course of anti-inflammatories. If that doesn't work, I can recommend a cortisone injection where we'll just drop a little bit of cortisone right on that nerve to see if we can get the inflammation resolved. We can also make a custom molded orthotic for the neuroma by incorporating that pad so that you can take that orthotic and just change them from shoe to shoe. Last resort is surgery. And then osteoarthritis. So I have a lot of patients that will come in here that have arthritis in different joints in their feet. So you can have it in the ankle joint, you can have it in the subtalar joint, mid-tarsal joint, the large toe joint, or any of the other joints. Most commonly occurs because of an injury. So it could be an injury even from 10, 15 years ago. It's not a recent injury. It's normally an injury from many years ago. I'll have patients come in and say, you know what? 15 years ago, I had an ankle fracture. I was placed in a boot. I didn't follow the instructions. I didn't go to physical therapy. And now I have severe pain. And normally when we take an x-ray, we're seeing arthritis in there. So several factors normally can cause that, right? So it's previous joint damage. If you've had damage from an injury, a car accident. If you are carrying extra weight, again, with the pandemic, most of us have kind of gained some weight because we have not been able to go out and work out and the gyms are closed. Also, we see osteoarthritis with increased age. So aging does cause us to have some arthritis. Some patients come in and say, you know what? My mother or my grandparents had severe arthritis in all their joints. And you start looking at not just their feet, but start looking at their hands and you're going to see that they have arthritis there. And normally those patients, it's genetics. It's not from an injury. It's not age related, but it's from genetic. And then poor ankle foot alignment. So we talked about poor alignment earlier with bunions or Hallux Limitus. Sometimes you just have a foot type that's going to end up with osteoarthritis. So it's hard once you have arthritis in the ankle joint or the mid-tarsal joint. It's very, very painful. And it's hard to treat that. We'll recommend supportive footwear. So we'll get you into like some orthopedic type of shoes. Most patients don't want to do that. We'll try some orthotics, whether it's orthotics, the custom orthotics that go into your shoe, or when you have ankle arthritis, we'll talk about an Arizona brace, which is more of it's a special orthotic for the ankle, which limits the motion in that joint. We'll try some cortisone injections. And the last resort is surgery. So With ankle arthritis is the picture on the left-hand side. We have some great surgeons here that are doing a lot, they're having a lot of success with surgery for arthritis in the ankle joint. They could do ankle replacements now. So if you've tried all conservative treatment methods and you're still having a lot of pain and you feel like you're healthy enough and you still want to be able to be active, I'd say see one of our surgeons. Now, not every arthritic ankle is a good candidate for the ankle replacement, but you can, have an appointment with one of our surgeons and they can discuss your options. And then the last one I put on that I see a lot of is ankle sprains. So ankle sprain is tearing of the ligaments or just stretching of the ligaments, usually on the outside of the ankle. It usually happens when, if you miss a step, if you are going down a curb and you roll your ankle, or we'll see it in a lot of basketball players. They're playing basketball, they come down, they land on someone's foot and they roll that ankle. Normally, we don't see that much instability unless you have torn and ruptured all of those ligaments. We have to treat that though. What a lot of patients will say, you know what, I just wanted to make sure I didn't break anything, but I want to go back to sports. We know that if you go back to activities too soon, we're going to see that you're too weak and you may lead to a different injury, and you can lead to all your ligaments completely torn, or it can lead to a fracture. If you look on that left-hand side on the bottom, the presentation is like, you'll see the swelling and the bruising on the outside of that ankle. Sometimes it radiates into the digits and sometimes on the inside of the ankle. Most of the time it's treated conservatively. We know that we can put you either in a boot or a brace. So depending on how bad and how severe the ankle sprain is will depend on whether you go right to a brace or do you start with a boot. So the high ankle sprains, we're going to put you into a boot and we're going to recommend that you use crutches for about 1 to 2 weeks. If you have a less severe sprain but you still have the swelling and some pain, we're going to put you in that brace on the top. We're going to recommend the RICE protocol, which is rest, ice, compression, and elevation. And that is very important that you do that the first 3 days of an injury. I tell patients, ice it 20 minutes on, 20 minutes off, 20 minutes on, 20 minutes off all day, because that will help with that swelling. We'll try some anti-inflammatories to get that swelling down. And after the swelling is down and you're immobilized for a short period of time, I'm going to send you to physical therapy for stretching and strengthening, and then the proprioception, which is the balance. And I highly recommend physical therapy for an ankle sprain because we know we've stretched those ligaments and we want to get them back into the right position, and we want to make sure that they're strong enough that the next time you go out, whether it's uneven ground or you're going to go out and play a sport, that you're able to do that without chronically rolling back. If there are major tears, if all of the ligaments are torn and you have instability, we're going to ask you to consider surgical intervention. And that's it. I just left some time for some questions, or if I didn't hit anything that you wanted to ask.
Great. Thank you, Dr. Gekas. Great presentation. Yes, we will get started with the questions and answers. There's a Q&A area at the bottom of the screen. Again, if it's too personal, I may have to skip over it, but we'll get through as many as we can. Let's see here. Sorry, I have to open this up. What is the sinus Tarsy syndrome and how long does it last?
So I'm going to see if I can get back to.
Dr. Gekas? Oh, you're on mute. It's,
Can you hear me now?
yes.
But nobody heard that.
All I heard was, let me get back to, so I thought you were looking for something.
No, I was just looking for this picture. This is the best picture I have of that. So the sinus tarsus syndrome usually is the pain on the lateral aspect on the outside of the foot. And normally what we do with that is like we'll try to mobilize you first by a brace, or depending on how bad it is, a boot. We could do a cortisone shot in that sinus tarsi area. I'll look and see how you walk. So is there any biomechanical abnormalities? Are you pronating too much? Are you supinating too much? Is that what's causing that sinus tarsi? And if it's, you know, a biomechanical abnormality, I'm going to recommend an orthotic for that. And, you know, sometimes, you know, patients say, well, how long is it going to take for the pain to resolve? You know, you have to be patient with a lot of foot problems because we walk on our feet all day long. It's not like we can sit down and not walk on our feet or walk on our hands. So you have to follow that, you know, you have to be willing to immobilize it and go into some different shoes to allow it to heal.
Okay, next question. How long can I expect a cortisone shot to make a difference?
So I'm not sure what that question is. How long does it take for it to start? Normally I tell patients like within 12 to 24 hours, you'll see some pain resolution with a cortisone shot. It will probably only last for about 6 weeks. So if I'm giving someone a cortisone shot, what I'm going to ask them is, you know what, this is not going to cure the problem. I'm only trying to get rid of the inflammation that's causing some of the pain. If the cortisone shot doesn't work the first time, I'm not going to recommend a second one. If you get some resolution of pain and it's helped, and you want to see if you can kick out a little bit more pain, I'll recommend a second one. But if it hasn't helped and it's 6 weeks, I'm not sure a second one will help. For feet, now I'm not talking about knees or any other joint, I'm just talking about for the feet.
Next question, how do you prevent arthritis progression?
So that's a good question. So arthritis progression, if you're talking about arthritis from like a Hallux Limitus or a bunion, that's just wearing the proper shoes and making sure that your toes aren't being squeezed in a shoe that's too tight or too narrow. Now, from an injury, you know, when you have an injury, if you have a severe injury where there's severe damage to that cartilage from that injury, like car accidents, right? You push down really hard on the brake and you break a bone and it's part of the joint. We know that somewhere along the line, it could develop into arthritis, and it probably will. It's just, you know, wearing, I know I don't think anybody wants to hear this over and over again, but it's usually just wearing the proper shoes. I know that if we're going to keep wearing high heels all the time, women, you're going to get arthritis in your joints. If you are wearing too narrow, too tight shoes, you're going to get arthritis in the joints.
There were some questions about footwear, but you went through that in the presentation. Is there any specific?
So when I talked about a rocker bottom sole shoes, for sneakers, like if you have the pain from the neuroma, I didn't talk about metatarsalgia, but that's pain in the forefoot too. Or if you have the bunion or the Hallux Limitus, I like a rocker bottom shoe or sneaker. So I know New Balance, I don't know if everybody has a pen or pencil, but New Balance 928 and 880 have a rocker bottom shoe. The Hoka series, the Hoka sneaker also has a rocker bottom sole. If we're talking about shoes for women, dress shoes, they might not be the dressiest shoes that you want, but there's Nayots, there's Merrells that have wider forefoot. You know, is it something that you would wear to a wedding or a function? No, but would I wear it to work? Yeah, I would wear it to work just to keep the pressure off of those.
Okay, thanks. Next question, Hallux Limitus, can exercise help with this?
So with Hallux Limitus, you don't want it to become Hallux Rigidus, which is when you have no like range of motion in that joint anymore. So if you keep exercising, is it going to stop that from progressing to Hallux Limitus, Hallux Rigidus? I think just staying active. We know that if you have arthritis, that the more you use your joints, the more motion you're going to keep in there. But is it going to eventually stop you from getting rigidus? No, that's, I think, a genetic makeup. You can see one person that has a Hallux Limitus, they've had that for 20 years and they never progressed to a rigidus. And then you have the same, another person, and it progressed to a rigidus really quickly, yet they did the same thing. They exercised, they wore the right shoes. That's more of a genetic makeup, but I do recommend for arthritis, just keep moving.
Okay.
Keep the joints moving.
Next question, hard bump on the back of an ankle. What is that?
So that is that's like a posterior spur. It's a Haglund's deformity. I don't have a picture of that, but that's right where if what I think is what he's describing, or he or she's describing, it's right where the Achilles tendon inserts into that heel bone, the calcaneus bone, and sometimes we'll see like a little bump there, a little posterior spur, and it gets inflamed. With that, I'll tell patients, stretch the Achilles tendon, because if you have a tight Achilles tendon, it's going to stretch that area, it's going to get inflamed, and it's going to get larger. So if you can begin doing some Achilles tendon stretches, that's going to help prevent you from getting a painful Haglund's deformity.
What do you do about pain in the ball of the foot?
Ball of the foot. So that, I didn't show a slide on that, but so the pain in the ball of the foot could either be from that neuroma that we had earlier, or it could be from atrophy of the fat pad on the bottom of your foot, and then gets the second and third and fourth metatarsal phalangeal joints will get inflamed. So normally what I ask patients to do is look at their shoes, make sure that the shoes are padded enough, right? They're cushioned, they're not very flat. Stay out of the heels. I would not recommend a cortisone injection there, because you can actually, there's a ligament there that can be ruptured if you get a cortisone injection in those joints. We could also put metatarsal pad in your shoes. We could put an orthotic in your shoe to kind of pad that area up. But the first thing you want to do with that pain in the forefoot, and we've been seeing a lot of that again with this pandemic because patients have been barefoot, is start wearing a pair of shoes. Start wearing a pair of sneakers to give you more cushioning. You might need some anti-inflammatory, so like over-the-counter anti-inflammatories to get that inflammation out will help also.
Thanks. What is the success rate of bunion surgery? Can an unsuccessful surgery be corrected?
So that's a good question about the unsuccessful surgery. So a lot of times when someone comes in and said, I had surgery and it didn't work, what we do is we take an x-ray. We want to see what the previous surgeon did to see, can that previous surgery be corrected? Sometimes patients will get a bunion surgery where they just take the bunion off, right? They just kind of take that bump off, but they didn't correct and push over the bone. So those cases, yes, if you get the bunion back, our surgeons here can easily fix that bunion. And it's just a second surgery where they're going to shift that bone over. And successful surgery, I think most of the time I see a very successful surgery with the bunion surgery. And again, you have to, I always tell patients, you have to, kind of buy into it. You're going to do the surgery, you must listen to the surgeon. If they tell you not to place weight on it for 8 weeks, do not place weight on it for 8 weeks. It is a surgery that does require you to be off your feet for a period of time, and patients after 2 weeks get tired and they'll start placing weight on it. So what happens is you've just kind of negated what the surgeon did. Everything they did to try to correct that deformity, now you're placing weight on it and it's shifting back over.
Good advice. Are there stretches that I can do for heel pain where I have neuroma?
Stretches for a heel pain and a neuroma?
Yes. Are there stretches that I can do for heel pain on right foot where I have a neuroma?
So There's no stretches for neuroma, but you could do stretches for the heel pain. You know, you could certainly Google. There's plenty of stretches just by Googling for plantar fasciitis and tight Achilles tendon. The one that I tell for the tight Achilles tendon, you know, if you have a step, just put your forefoot on the step and lower that heel and count to 30 and then go back up. And I'll tell them to do that stretch 10 times, and that will get that tight Achilles tendon. And the stretch for the bottom of the foot, I'll tell patients just take a towel and barefooted, just kind of try to move that towel with your toes. That's not going to irritate that neuroma, but it's also not going to help that neuroma. The neuroma is inflammation on the nerve itself.
Are toe spacers effective on repositioning a bent large toe?
So that's a good question. I have a lot of people that come in here and they have a lot of different contraptions that they found either at the, the supermarket, at a pharmacy, or on online and Amazon. So I always tell patients, if you're putting those toe spacers in, as long as you have that toe spacer in, it's going to keep it separated. The minute you take that toe spacer off, that joint's going to come back. So if you're using it because you think you're going to correct that bunion or that hammer toe, it's not going to work. If you're using it to be more comfortable in a shoe to keep the toes separated, that it will work for that.
Okay. Next question. Can you address pain on the top of the foot, the top side of the arch specifically?
So I'm thinking that they're probably talking about the mid-tarsal joint, which would be right about here. So that's kind of on top of the arch. If you're having pain there, I would recommend an x-ray just to see if there is arthritis in those tarsal metatarsal joints. If you have a high arch foot, or if you have a flat foot, we're going to see some kind of possible arthritis in that area. So if you haven't gotten an x-ray yet, I would recommend getting an x-ray to see what's going on in that area. And then also just kind of evaluate your shoes. Are you barefooted? If you're home, working from home from this pandemic, start putting a pair of shoes on. And not just like socks or slippers, but put a good pair of like sneakers, outdoor sneakers, running sneakers. And then just because, there's a lot of things that could cause that. Do you have a stress fracture? Have you been working out? And is there a possibility of stress fracture there? So the first thing I would definitely do is get an x-ray.
Okay, which all of, when you're a new patient with us, x-rays are included in the visit. I am told that the flexibility will never return to a big foot after it is broken. Is that always the case?
So it all depends on where the fracture is in the big toe joint, right? So if the fracture occurred within the joint, so it's on the bone and the fracture line went into the joint, you may get arthritis there. If it's a fracture to a toe and it did not get into the joint, then you should still have motion available to that joint. So I'm thinking if you had an injury and to a toe, and you have lack of motion, I'm thinking you probably had an injury that went into the joint itself and caused arthritis.
Okay. Two more shoe wear questions. Are Birkenstock sandals good for plantar pain?
Yes, that's one of the sandals that I will recommend because it has a good arch support. I recommend Birkenstocks, and Birkenstocks now started recently making shoes, so I'll even recommend the Birkenstock shoes for plantar fascia pain. I don't know if I said this, I think I did, but I want to keep you out of flip-flops or like slides when you have plantar fasciitis because they're not supportive enough. But if you go online, there are shoe companies like Bionics and Chaos that have a better sandal or flip-flop that will be, if summer's coming. So if you want to wear flip-flops, think about a better flip-flop than the normal flip-flops that you've been wearing.
Okay. There are a couple personal questions, but they all are in line with each other. People having osteoarthritis in their joints and now have large bony bumps at the top of their feet. Is that?
So that is osteoarthritis, and that's normally, when you start seeing that, that's probably in the mid-tarsal joint, right? And that's hard. That's, with that, how do you treat that? Well, first I'll tell them to get better shoes again. I know you guys are all tired of, hearing me say that, but it's hard to accommodate that in shoes. I also will tell patients, if you're wearing tie shoes, skip that lace. So kind of take the lace out of that eyelet and just go to the lace above it. That will kind of keep some of that pressure off. If that doesn't work and you're still not comfortable with shoe gear, any of the shoes, then I would recommend surgery for it.
Okay. What is sinus Tarsy syndrome?
I think we answered that one already.
Oh, she said she didn't hear the answer. Sorry.
Oh, the sinus Tarsy syndrome, I must have been muted. I'm sorry then. So sinus Tarsy syndrome is usually pain on the lateral aspect. It's right below the ankle joint, right? And you're getting pain in that sinus tarsi. So when I see a patient like that, what I want to do is I want to evaluate to see if there's any biomechanical abnormalities. I will immobilize you for a period of time just to see if we can get you calmed down. You could try some anti-inflammatories. We'll even try a cortisone shot into that joint. But if we can determine what caused it, usually biomechanical abnormality. So, do you pronate too much? Do you supinate too much? What's causing this? And then we'll recommend the right shoes or custom molded orthotics.
If you have custom orthotics already, how long do they typically last?
So I tell patients it all depends on how much you wear them, hopefully all the time, and how what do you do for a living? Are you out in the in the cold and the water all the time? They're going to break down a lot sooner. I normally tell patients about 5 years, and normally I can repost them, but by 10 years I would say that they need to be replaced.
And I know you have patients to get back to, so we have a ton of questions coming in, and so I'm sorry if we don't get to them all, but I'll just do a couple more. Someone who is doing all that you have mentioned, but Motrin seems to really help. How long can they take that indefinitely? Or how much can they take it indefinitely?
So I don't like having patients on any anti-inflammatories for longer than a month, because what you're doing is you're taking that just to relieve the pain, and you're not really addressing what's causing the pain. You also have to worry about GI issues. When you're taking long-term anti-inflammatories, you can create an ulcer and a bleeding ulcer. And if you ever talk to any of these GI doctors, they'll say, we really don't want our patients to be on long-term anti-inflammatories. So I'll keep someone on it just for a month. Maybe the most I'll do is 2 months. After that, I won't give you a refill because of those possible complications with a GI problem.
And then if someone cannot take NSAIDs by mouth, what else can be used to relieve some joint swelling?
So, and that's a good question. There are topical creams now available out on the market. Voltaren just came out topically. There's BioFreeze. So if you can't take any anti-inflammatories, then I'm going to recommend something topically.
All right, last question. Does it matter if you're wearing a sneaker that says it's for running, but you're using it for walking?
Absolutely not. Running sneakers are actually, I think, a little bit more supportive, and they have a little bit more cushioning, because you got to remember when you're running, it's about 1.5 to 5 times your body weight. So you're going to want more cushioning. I tell people, and I think I did not bring this up, but normally sneakers lifetime is 300 to 500 miles, right? So your sneaker might look perfect. It looks great. But if you look on the bottom, the treads are starting to wear out. And if I keep track of how many miles I run in my sneakers. And so I can tell about by 325, 350 miles that I need a new pair of sneakers. But if we all wear some kind of tracking device, whether it's a phone or a Fitbit or if you can just kind of remember, when did you buy these sneakers? I will actually kind of pick a marquee, and I'll mark up my sneaker, telling me when I started with the sneaker, and I can track with my phone how many miles I have in those sneakers. I know I got to get rid of them in 500 miles. But you're going back to that question is, running sneakers are just as good as walking sneakers if you're going to be walking. Now, that being said, I would rather my runners wear a running sneaker than a walking sneaker. And again, start looking at your sneakers and making sure that the tread is not worn down on the bottom, and try to kind of figure out how many miles you've gotten on those sneakers.
Great. Dr. Gekas, thank you so much. I know you have patients you have to get back to. Thank you for
Thank you.
time. Again, if anybody needs to schedule an appointment, please feel free to use our VIP number. I put it in the chat box, but if you have a pen and paper, I'll repeat it right now. It's 610-480-6584. Unfortunately, there are a lot of questions that came in and I didn't get to them all, but Dr. Gekas, I know, would be happy to talk any more specific questions to you and within an appointment if you have that opportunity. She sees patients in Bryn Mawr, Glen Mills, Media, and South Philly. So thank you so much. Everybody have a wonderful day.
Thank you.